Good evening, everyone. We have a session. Dr. Victor Umeh of High Foundation Hospital, Ikeja, Lagos, will be presenting optical coherence tomography and geography, optic nerve head, and retina. Dr. Victor Umeh, I believe every one of us will have a very educative and enlightening session with him this afternoon. Dr. Victor Umeh, you have the floor. Please, you can start your presentation.
Okay, thank you. Good afternoon, colleagues, senior colleagues, and I'll say friends. I'm Victor Umeh, and by the privilege of the Young Ophthalmologist Forum, led by our able chairman, Dr. Bature, I'll be presenting this discussion today, and I thank you for the privilege to share with every one of us today. I pray that this time spent together would be very stimulating and also educative. So it started out as a discussion on the forum that's led to this. So I'm going to go through this quickly so that I would have time to ask questions and then take some feedback. So I'm going ahead right away. So I want to ask if my voice is clear.
Yes, it's clear. You are audible.
Okay, thank you very much. So I'm starting right away. So we'll go through this under this topic under this following headlines. And I had requested earlier today, because of the brevity of our time, we may just do the optic nerve head aspect of OCTA, and then at another time we would dive into the retinal part, which is actually much more bulkier. So these are the disclosure. The images in this presentation are from the OCTA machine we use here in our center, which is OptoView, Fora domain, and the resolution is stated here. So this is just the earlier parts. Some time ago, I had the privilege of discussing the OCT retina. So this just, I included this for those that were not parts of that discussion that day, just introducing the OCT as a landmark ophthalmic investigative tool, giving a live biopsy of whatever tissue, ocular tissue, and the whole intensity and the principle, the interferometer principle. And we said that day that the OCT is not an ophthalmologist and does not take away the aspect of clinical reasoning, history taking, examination, and judgment calls. So this is just about the OCTA, but for the OCTA, the printout and the parts are still the same thing, containing the following features listed here. I'll just jump through this and then this is about OCTA and glaucoma. So it's noteworthy to talk about glaucoma as still the leading cause of irreversible blindness, and we know the prevalence in our country. But this OCTA became crucial because there are many theories to glaucoma. One of them is the vascular theory, which posits that glaucoma could be a vascular disease with resultant ganglion cell death due to retinal nerve fiber layer ischemia. And that led to several investigations and evidences emerging as showing that impaired optic nerve head perfusion may be contributory to the pathogenesis of glaucoma. And that's the vascular theory. And this is independent of the pressure mechanism, which is known for glaucomatous optic nerve damage. So after this has been stated and several thoughts have been put into it, the next question was, how do we check the vascular supply of the optic nerve head in persons with glaucoma. How do we check it in persons that are normal? So several things came into place. The first studies were histopathology of persons that were already deceased, and it showed that their nerve fiber layer thickness was reduced and the vessels were also reduced. And then that's cascaded into different form of imaging, notably the angios with dyes and different contrasts, and then the Doppler systems, and then even some OCTs that have Doppler system. But the issue with those is that those Doppler systems and the dye systems majorly capture flow in bigger vessels, larger vessels, and the optic nerve head, the retinal nerve fiber layer vascular supplies are tissue capillaries. So they could measure the ophthalmic artery and vein and all, but when it gets down to the tissues and to the capillaries, it becomes an issue. And this is where the OCTA came into place. Being non-invasive and reproducible also makes it handy for clinic use. So it's non-invasive. The images gotten can be in 3D, and you don't need a dye, you don't need an external dye, and it's a static scan with the area of interest, so it's limited, although there are development of wide field OCTAs now. The images are representable, but unlike FFA and ICG, there are no leakages and it's not time-based. Okay, so the principle is, there are several principles to the OCTA, but the most common one is the amplitude decorrelation. What this means is that the SSADA, the split spectrum amplitude decorrelation, it just partitions the tissue of interest into different spectrums, and it's checking the amplitude of movement of the red blood cell through the vessel at the time. So the OCTA uses the heme pigment on the red blood cell as its own contrast. So there's a contrast, but it's not an external contrast, it's hemoglobin. So it tracks the movement of the red blood cell within the blood vessels of interest at the time of capture. So what this means is that if there's no red blood cell motion within the vessels at the time of capture, the area this happens will be dark and will appear as dark patches on the scan, and it will reflect as no vascular supply in that area, and the vessel will not be represented. There are other systems like the microangiography system, but this SSADA is the most commonly used. So for the interpretation of the results, we still have to go through all this, the biodata, the date of the test. Biodata is more like the patient, the age of the patient, the eye of the patient. In some places, they make room for presumptive or pre-test diagnosis. Signal strength, segmentation. When we discussed OCT the last time, we talked about segmentation, meaning that what you find depends on where it's the OCT scans and the level, meaning that segmentation could be at different levels. ILM, inner plexiform, and RPE and Brooks are still the ideal taken in many machines. So we'll still have to go through that. Then normal and abnormal finding. So I'm going straight to the optic nerve head OCTA and how that affects our discussion today. So the first part is the vascular theory of glaucoma, which I have stated that glaucoma is being recognized as a vascular disease with an ischemic component independent of intraocular pressure. Now, the vessels of interest are the radial peripapillary capillaries. It's a long name, but I'll shorten it. It's RPC. Radial because they radiate from the optic nerve head, just like the retinal nerve fiber layers. Peripapillary because they surround the optic nerve head. Capillaries because these vessels are at the capillary level. So, and that's where oxygen transfer, oxygenation, and all happens. So they are capillaries. So I think I've been able to break down the name. Then vessel density, I will explain, and then the significance of all this. Now, the part of the vascular theory of glaucoma is that impaired perfusion is contributory, and reduced ocular blood flow have been noted in the optic nerve bed of several glaucoma patients. And this comes into play, especially from different tests and from different studies, that some patients, despite adequate intraocular pressure control, still have progression of the glaucoma, okay? And that brings the question, what else is contributing if not pressure? So this makes room to believe and to investigate the vascular theory of glaucoma and see if that holds true. So now this is the OCTA angiography of the disc. So like I mentioned earlier, the optic nerve heads, it's supplied by the RPCs. The OCTA is able to look at these capillaries, quantify them, give us counts, and also give us a qualitative scan of defects on the optic nerve head. And this is by following and tracking the motion of the red blood cells as they pass through these capillaries, okay? So that's what I've said in short. So now that brings us to a good terminology that we should always remember, and that is vessel density. Because the test results is given in vessel density. So now the vessel density is the perfused area on the scan expressed as a percentage of the total area or its predefined sectors in a retinal layer of interest. So what this means is simple. If at the time of the capture of this OCTA, if 50% of the area of the optic nerve head is perfused, the result comes out as 50% over 50 over the total area that was scanned. So this is a way of the result coming out as the vessel density. This is the quantity, this is the count of the area capillaries that were perfused at the time of the capture of the test. So the result is in percentage, and the machine will render it to you in percentage. You see it print out, and then you have to interpret what goes on. Okay, so I've mentioned this now. So what we have available in studies is that the RPCs and optic nerve head flow is reduced in glaucomatous eyes. And there are close relationship between severity of the glaucoma on visual field analysis and vessel density reduction on OCTA. And then the reduction in OCTA has been shown, this is a key point, to occur before the typical visual field losses and also to occur before the reduction in retinal nerve fiber layer thickness from studies. What this means is that vessel density reduces first, retinal nerve fiber layer thickness reduces second, and then visual field changes occurs. So one of the things that is common in glaucoma that has been mentioned and that has been repeated is the impact of disc hemorrhages in patients with glaucoma, especially normal tension. It is thought and it is shown that having a disc hemorrhage is a sign of progression. Why that is true is because after the disc hemorrhages has cleared, the next thing you see in the retinal nerve fiber layer thickness is rake defects, meaning areas where the nerve fiber layers are lost around the area of the hemorrhage. And so that is easy to accept in terms of if OCT is coming ahead of visual field changes in detecting glaucoma, being that you need to lose fibers to a particular quantities, 50 to 75, to get the typical visual field changes on white perimetry. The OCTA has been taught and has been shown to have a reduction in vessel density before the nerve fiber layer losses. So, okay, so just as a repetition, the vessel density is the perfused area expressed as a percentage of the total area examined. Okay, so the next issue will be, what is the normative data? Now, the part of what I'm sharing here is the result of my own dissertation in West African College of Surgeons. I had to study the OCTA in optic nerve head, and the result we found was similar to the database of Caucasians. And for me, that's what we're applying in interpreting the results in our center. Now, the average vessel density is seen to be between 52 to 56 in normal eyes, although in Caucasians, it could be as low as 50. And significant reductions occur in persons 60 years and above compared to the younger ages, although there are no significant reduction for those between the ages of 40 and 50 when those two age groups, 2 decades of life, are compared. And there are thoughts that there may be some impact of systemic diseases on this. Okay, so let me get into the test itself, and then we'll come back and look at this. So the sequence for interpretation still applies. You look at the biodata, the date, the time, the eye, the test algorithm, the quality, then the segmentation. Usually, the one we use have a retinal nerve fiber thickness map on the left, and then the vessel density on the right, and then we'll compare and make a decision. So I'm showing you a first. This is an OCT of a patient. The patient is 61-year-old female that has glaucoma. So in her own instance, it's an angle close-up glaucoma. And then the right eye is more affected with the nerve fiber layer losses depicted from the average retinal nerve fiber layer thickness and the color code here. The left eye is almost normal because the laser iridotomy was done quite early in that eye compared to the right eye. So I'm showing you this so that I can show you the vessel density and would pick up from there. Now, this is the vessel density printout of the patient, and I'm going to highlight some important things on it. Okay, I don't know, this is not, okay, so for the upper part, you see the scan, I've removed the biodata part of this test to protect the patient's interest, okay? So the biodata, name, age, sex, and all that have been, time of scan has been taken out. So what we have first here is an SLO image where my arrow is. Now, the next image is an OCTA angiography, but the level at which the scan scanned is the vitreous retina above the OPL. So this is not the scan of interest for optic nerve head changes in glaucoma. The next scan is the scan of interest. This you can see RPC, ILM to nerve fiber layer, because the capillaries are embedded in the nerve fiber layer in the RPCs are embedded in the nerve fiber layer. This scan is not so clear, and that reflects from the quality of the scan. You see the scan quality above, it is 4/10, but this is for illustration. The other scan is at the choroid level, and it's not the scan of our interest here. So if you look, you'll see that you have a yellow mark that tells you where the scan is from. This is down. Down means towards the choroid. This is up here towards the optic nerve head. Then down to the scan, if you go to the left where my arrow is now, the scan does an optic nerve head analysis as you have on the OCT, where you have the curve disc ratio, curve disc area, vertical horizontal rim area, disc area, cup volume, and down you have the retinal nerve fiber layer thickness, the peripapillary nerve fiber layer thickness, okay? This 74 is the average. So here you see the superior is 90, inferior is 81, nasal is 86, temporal is 36. If you're already judging, you would agree that the nerve fiber layer thickness is reduced if you don't have a color code here, because it's meant to be, this superior and nasal are meant to be around 100, 112, 115, 120 or thereabout. And that's what is represented on the scan that the arrow is pointing to now, okay? Now, this scan, next scan that I'm pointing to is the vessel density scan. And I would show you from where it starts. The box below the rightmost image is a summary of the vessel density. There are three components to it. You see RPC, that's RPC density in percentage, small vessels, all vessels. The small vessels constitute up to 80 to 85% of the vessels of interest. So the whole image is one parameter. There are vessels inside the disc, and we have lastly, the peripapillary vessels. The most studied one is the peripapillary vessel density. So, and it is now divided into superior hemisphere and inferior hemisphere. And you see the figures here, 4.5.4 for superior, 47.3 for the inferior. Down to the its own numerical mapping. It's written here, 45 for superior hemisphere and 47 for inferior. And when you go down to the sectors, you will see here that inferior is 49, superior is 47, nasal is 44, and temporal is 49. These are taken from this current map that I'm pointing to. And if you look to the map, I'll show you something. The quantitative part is counting, seeing the numbers display, while the qualitative part is looking at the numbers and the area of interest and finding out that there are areas that appear bluish in color. Those bluish areas are areas of capillary non-perfusion at the time of this capture. The areas of capillary perfusions are warmer in color, having green or red, like this one now is 50, is green. I'll get you an area that is 43, for example. Here, you could see this dark patch area. That's an area of capillary non-perfusion, okay? Yes. So this is the first. So the first thing will be to look at the map itself, the printout, the colored map, look at the numbers, see the summary of the numbers, and then you look at the qualitative part of it, and then see the areas where you have your dropout. You can judge whether this is a superiorly or whether it's the inferior part, whether it's temporal or whether it's nasal. So I'll go to the next scan, and then I'll go over this again, and hopefully we'll see. So you will remember that on this map, the average is 45 for the superior and 47 for the inferior. If you take an average of everything here, it will be 46 for this eye, okay? Now, I'm on another graph. So this one, the scan quality is better. The scan quality is better, and we could see, let me go from here. So where my arrow is the RPC OCTA. You see the fine striations of the capillaries depicted as a mosaic pattern around the optic nerve head. This is the optic nerve head. These striations are the capillaries. I'm not talking about the big vessels. The larger ones are the big vessels. They are not the vessels of interest. The vessels of interest are the fine capillaries. So these ones here are the ones within the disc. These ones here are the ones peripapillary, and they are the RPC. Radial because they are radiating out from the disc. Peripapillary because they are around the disc, and capillaries because they are capillaries, the type of tissue they are. So on this other end, we now have the summary. RPC density, whole image 50.2, inside it is 50.4, peripapillary 52.7, divided into superior hemisphere 54.0, inferior 51.0. Down to the map, we'll see this. Here is 55 around the superior area. This is also 61. This is superior area too. Towards these nasal parts, you have 46, and you can see some areas that are dark bluish, areas of non-perfusion at the time of image capture. The warmer areas have better perfusions. Okay, so goes round, and this is the summary. Okay, now seeing this figures, the next question would be, what figure is normal? What figure is low? Like, if this was color-coded, if the figures were color-coded the way OCT is color-coded, most of us will not ask the question. And that's where studies and research came into. So I'll just share what I found from my own study in Eye Foundation Hospital about this. That was just to get a normal data. So I'll show you this. This is why this will make sense now. So in the study we did, we compared persons with early glaucoma with persons that are normal. The three things we got out from this is to get what the normal vessel density would be for a normal person, and then we'll get the one that we're getting the mean for normal eyes, the mean for early glaucoma eyes, and compare to see if there's any difference, and then see how the distribution occurred. So I'll show you this here. So typically, the average is when you add up inferior, superior, nasal, and temporal and divide by 4. The machine renders it too on the printout. So the average for the normal eyes was around 54.6 plus or minus 2.5%. That's to say from 52 to 56. Why the early glaucoma guys were around 50 plus or minus 4.5. That's like from 46 to 54. And for all the quadrants, the normal persons had more vessel density compared to the early glaucoma patients. Okay. So what we took out from this, the normal for from our study for Nigerian eyes is 54 plus or minus 2.5. So that takes into account up to 52 to 56. Although Caucasian eyes, 50 is normal in some of them. And there are other slight variations, like in high myopia, it could be lower and all that. So I will take us back to the results so that we'll be able to put some figures in mind. So I'll just say, if you want a random figure, it's usually 50-51 for normal. That's for quantitative. The qualitative is a decision of the physicians. You look at the nerve fiber thickness, you look at the vessel density, you make your judgment call, and I'll take us through that too. Okay. So some of our findings, just as a broad base, is that there were more vessels in the superior and inferior quadrants and the temporal quadrant too. So, and then when it came to the distribution, the temporal quadrant had more vessels compared to nerve fiber thickness, and that in interpretation means that they do not obey the Ising rule of retinal nerve fiber layer distribution. So in this instance, the temporal has as much as the inferior and superior. And the temporal, which observe the papillomacular bundle, is easy to deduct that the papillomacular bundle has richer supply. And the next question will be, how is this important? So I will say, and I will tell you, and other persons have actually denoted that the resistance to glaucomatous damage attributed to the central part of the vision, as we'll say, the tail end is tunnel vision, the superior fibers are affected, the inferior fibers, but the central part is still there. Could be due to this vascular supply that makes it more resistant to glaucomatous damage. So that's the thought I had after we found this out, okay? So I'll go over this scan again and allow us to think along with me as we look through it. So now here the superior is 38 and the figure in my mind is 52, 51. Although the older the person is, the more likely a lower figure would serve. Like I said, for those 50 years and above, 60 years and above, theirs were significantly lower. So on this scan now print out for the vessel density area, we have 38 superiorly and 44 inferiorly. If I use a benchmark of 50, the vessel density is already reduced. Then nasally is 42, while temporally is 50. So the other thing I didn't tell you about this patient is that her vision is 6.9. With correction, it is 6.6, despite the glaucomatous damage that we have here. So this eye still has a 6.9 unaided vision and 6.6 with correction. Okay, so here 44, 49, 44, 49 here. So with this, for that same right eye, the vessel density is low. And the nerve fiber layer thickness also has reduced, okay? So this is a given. The next one here, this eye, the average for this eye is about 52.7. And we take into account 50, 51, 52, depending on the age. If you're younger, if a patient is younger, 40 years, I'll be saying 52. If the patient is older, 50 can serve. So in this patient, the vessel density is still okay in this patient. The nasal quadrant has some reduction. Here we have 44, and then that shows in the dark bluish areas on the colored map here. And then reflecting on the nerve fiber layer thickness on this side. Now, and that's where I want us to give some attention. So the retinal nerve fiber layer thickness on the temporal side is 79, and the vessel density is 56. While that of the superior is 182, the vessel density is 58. Inferior is 156, the vessel density is 56. Nasal is 103, the vessel density is 44. That is to say, we have more fibers sharing fewer capillaries in the superior quadrant, 182, 152, 58, 156, 56, compared to the temporal quadrant. Okay, so usually the aspect of glaucoma that we talk about, the inferior and superior quadrant are usually the more assaulted ones, and that could be attributable to they having more fibers to fewer vessels. It means that for each vessel, for each capillary that drops out, more fibers will be affected, okay? So that also brings into the account why they are more affected and why the temporal quadrants seem to be more resistant. Okay, so I've put some more images for us to look through. So on this one now, this patient is about 58 years old, and I'm showing you this first before I show you some other images too. So here we have 38 superiorly, 44 inferiorly, 42 nasally, and 50 temporally. The average in this patient is 43.9 for the peripapillary vessel density. And the average retinal nerve fiber layer thickness is 73. Usually, the nerve fiber layer thickness should be between 100 and above, depending on the on our own machine, on this machine, 100 and above. Okay, yes. So the bluish areas are the areas of non-perfusion, or the non-perfused areas at the time of the image capture. So this, I'll show you the next, and then I'll show you the colored OCT scan, just so that you make your own deductions. Okay, yeah. So this is the OCT scan of this patient. With the color coding of the OCT, you can actually see that the patient has reduced fibers inferiorly and superiorly, more inferiorly, because of the areas of significant fiber loss, given the red color mapping. The temporal aspects and the nasal aspects, the temporal aspect and the nasal aspects seem to have more fibers, retinal nerve fiber layer thickness. This is RNFL map of this patient. So I'll take you back to his OCTA again. Now look, the inferior is down, this is 44. The superior is down, this is 38. The temporal still has some more fibers, 50, which is very good. The nasal has 42, which is good compared to the number of fibers contained in that area. Okay, so okay, so I would ask a question now. Are we clear so far? No, so far, are we clear?
Yeah.
All right,
okay.
Let me unmute participants so that they can make them.
Okay. If we're clear, we can go on to the the next scans, so that we'll practice more, and then we'll take some questions. Okay. Are we clear?
Yes, we are.
Okay, so I'll put in the next scan, and I would want you to, on your own, look at it, make your judgment call of what you think about the results, and then I will explain it. So, yeah, so I'm putting the retinal nerve fiber layer thickness first, so that you look at it, and then we'll look at the OCTA, and then we'll talk about it. Okay, so this is the retinal nerve fiber layer thickness. The average for the right is 98. That's nerve fiber. The average for the left is 97. Okay, I've removed the biodata part of the patient, but I'll tell you. So this is the vessel density for this blocks my view. Okay, this is the vessel density for us to look at. How do they remove this? The control panel on top is actually blocking my view for the upper part of this How do I take this out? Okay. Okay, so this and then this. So the judgment call here would be to look and see the vessel density of the superior quadrant is 50, the inferior is 47. Going around, the inferior quadrant is 47 in this eye, the superior is 54, temporal is 56, nasal is 39. Okay, and then you watch and see the vessel, the nerve fiber layer thickness is 135, 136. If we judge by the average in this patient, we'll have an average of 48.3. But if we go to the sectors, to the different sectors, we'll find out that the vessel density in the inferior quadrant has dropped, it's reduced. here. This is 47. And it has a nerve fiber layer thickness almost equivalent to the superior that has 54 for the vessel density. Now, if this patient is a young patient with a family history of glaucoma, and I'm seeing this patient at this time, and I see this result, all is not well, even though the nerve fiber layer thickness here looks good. Okay, this scan is for the right eye. This here, there are some losses on the nasal, upper nasal area here, but it's not now. It's just borderline. But here, the vessel density inferiorly is already reduced, and the fiber layer thickness is still normal. So if this patient is a young patient, average vessel density is around 48.3, is less than 50. Nerve fiber layer thickness looks good, and the CVF of the patient is clear. If the patient is a patient with a family history of glaucoma, all is not well. Why all is not well is this. The vessel density is postulated to reduce first before retinal nerve fiber layer thickness reduction. So this should be a patient for a closer monitoring and follow-up. And as we'll talk later, as we'll see in the later part, this kind of patient is also a patient where neuroprotection becomes important. So if this patient is going to be placed, pressure may be okay. If this patient is going to be placed on close monitoring, you have to reassess this vessel density, given a timeline of, say, 3 or 6 months for a judgment call. If you still have a further reduction in vessel density and there are no systemic vascular risk factors, then it begs the question of what do we do here and now? I'm not an authority in glaucoma, but I'll tell you one thing. The OCTA is going to revolutionize care, especially in the aspect of neuroprotection. If we would have medications that would increase vascular perfusion as their sole mechanism of action, then the OCTA will be able to re-image the eye and see if the vessel density improves or remains the same over a long period of time, for which you may not expect loss of nerve fiber layer and the visual field changes. Everybody must not agree, but if that happens, it will open a new frontier for glaucoma care. All right, so I'll take you to the other eye. This is the left eye. The vessel density here for the inferior part is 53. This is 53. Here is 54 for superior. So if I judge with 50 or 52, it's above board. Now, nasally is 43. Where's my picture? Nasally is 43, and temporally is 56. And then the fiber thickness looks relatively similar. So this eye will be expected to be healthier. This left eye will be expected to be healthier than the left eye, except if something else happens, traumatic or other systemic vascular issues, because the vessel supplies are much more compared to the other eye. Okay, so all right, so I would put this here and I want questions on this scan regarding the vessel density. That way, I'll be sure that that's the only feedback I can get. I'll be sure that we're on the same page. Okay, so anyone, you can type into the chat, or 1 or 2 persons can unmute and then ask a question. If you if there's any part of the scan you are not sure of, and this is relative to optic nerve head and glaucoma, okay, please go ahead, ask your question. In attending to it, I may be able to clarify it, a few things further.
Yeah, Dr. Umeh. Yeah, this
Yes.
like a similar case to the one we treated earlier.
Yes.
It has a good scan quality. And when we look at the
Yes.
vessel density, we have an average peripapillary vascular density of 50.7. I don't know the age of this patient.
Correct.
Yeah, so.
Yeah, I'll give you the age of the patient. The patient is 41,
Okay.
41-year-old female.
So we can still consider him among the younger age group, right?
Yes,
So,
but I will now give you another history that is family history of glaucoma.
okay, so we have a positive history of background family history of glaucoma. So looking at the vascular density distribution, we have the inferior quadrant 48, which is lesser than the superior quadrant 53.
Yes.
And
yes.
if you go to the particular quadrant, the inferior, superior, nasal, temporal, still the distribution is almost similar, but it's a bit higher than expected for that age, right?
Okay. No,
Because
it's not higher.
in 53,
it's
for 41 years.
Yes, so the normal is between 52 plus or minus 4.
Yeah.
Okay,
No.
so the younger the person, like somebody that is 40, I'll be choosing 52 as a landmark.
Yeah.
Okay, 50, 52. Now, then somebody that is 60, 50 is admittable. Is admittable as in a normal vessel density. Okay, that's at the average, general average. Yes.
Yeah, so the general average in superior quadrant is higher than the general average. However,
yes,
there is violation of isn't-true distribution of the vascular density. So, and the same for nasal temporal. And when we look to the left at the RNFL thickness, we have almost similar picture. So, because if you look at the inferior quadrant, you have 94, while the superior is 107.
Yes.
With a background, well, I don't know. The average peripapillary small vessel density is 50.7, and we're expecting nothing less than 52 in this patient. Yeah, so with positive family history, I think this is an indicator for an early glaucoma, maybe pre-perimetric. Is a patient to watch over,
Yes, so this patient having a family history changes everything. Is a patient to watch closely, and then this scan could be repeated after 6 months, and along with the OCT. If you judge with the OCT, I'm going to bring up the OCT. If you judge with the OCT of the patient, you would actually notice that there are some losses already, although they are minimal. And then if you submerge the areas of minimal losses to the whole count, you will say everything is fine because the summary of the indices all is in green. But now having a vessel density that looks this reduced means that you'd have to follow up the patient closely. And even if the eye pressure is okay with glaucoma phasing, is fine and all, if there are medications that help neuroprotection, if the patient is going to be started on anything, then neuroprotection will be the first line of care, not pressure reduction. That's it, yeah. So somebody said he noticed that the inferior quadrant, or she noticed that the inferior quadrant is always lower. It's not always the same, but I've selected some ones that have some specific things for discussion. It's not always lower. In some persons, it's actually higher. Although the superior quadrant gets to have more supply comparatively, more fiber thickness. But when you start analyzing it lower down, you'd see that the temporal has more supply. Okay, someone raised their hand, please. Please, there's a hand raised, please.
Yes, good evening. This is Professor Nokoya. Yes,
Good evening, ma.
Good evening. I want to thank you for this presentation. Now, I want to lend in a voice on the issue of the person who said she noticed that the inferior quadrant is always, yes, the reason is because if you look at the trunk of the vessel, you know, the inferior temporal, that inferior temporal is the farthest from the trunk of vessel. So that's another explanation whereby that is where you notice the early drop in capillary closure. So, you know, glaucoma is now being viewed as a vasculopathy. And that is why this OCTA is very important, particularly in those patients. For instance, those patients that you presented, the 41-year-old. Yes, I quite agree with you. These are patients that you really have to keep a close look on. And in fact, there's family history, so this patient should be started. Now, the issue of neuroprotection, yes, that would have helped, but you still have to lower the pressure. Okay, it does not matter what the pressure, you still have to lower the pressure, because if you remember the excitotoxicity theory and the issue of raised intraocular pressure, how everything goes, and you have distortion at the optic nerve head with remodeling, you know, it's all because of the cascade of reactions, the chemical substances that are released, the IL-6 and all the other things at the optic nerve head that causes the damage. And this also affects the vessel, and is basically because of the intraocular pressure. So whatever we are doing, even when we eventually have the neuroprotective agents, which we don't have now, and I can tell you that categorically because at the last World Ophthalmology Congress, that issue came up with, you know, the top people, Weinreb, and he was saying, they were all saying that, look, all these neuroprotective agents we're talking about, that none has been clinically proven. In fact, that the one that we all depend on, which is the brimonidine, the alpha adrenergic agonist, is not really a neuroprotecting, not a neuroprotective agent. But you can go in the way of what we know, like the naturally occurring substances, which we know have the nitrites, you know, the vegetables and all that, that until that is made available, you know, you can make use of that. But what you still have to do is lower the pressure. And that's where we still are. Thank you.
Thank you very much, Ma. Thank you so much. When you have a professorial contribution, it's time to end the meeting. I think Prof has answered all the questions of all the people that want to ask anything. Yeah. Okay. So just to put in a few things before we go, except there are other questions. Now, the part of applications that will become very important going forward is in patient normal tension glaucoma. If the tension is normal, it's controlled, and you have progressions, you have to start looking not just at neuroimaging, but also vessel density. Family history, if members of a family can be checked and you see that their vessel densities are low, even when they've not developed the clinical signs of the glaucoma, we may be able to start looking forward to additional care in addition to pressure lowering, like Prof has actually buttressed in her contribution. So neuroprotection, early diagnosis. There are a lot of promises with OCTA because of what I've mentioned earlier, that many researchers and studies are pointing towards vessel density reduction before retinal nerve fiber layer losses and then visual field changes. Can it help us monitor care in a better way? It could. We don't know yet. So if we have medications that we are looked to have neuroprotective effects, this might be a way to test them. If we're having a faster progression of disease despite care in a pattern that looks beyond glaucomatous, it may be good to have an OCTA in addition to the neuroimaging. So this could also, OCTA could be the new frontier for drug development and then impact of surgery. We never can tell whether trabeculectomy has an impact in increasing vessel density until we try out to see what the vessel density was before and after. Actually, Gabor Holo, that used OCTA, he used it first on his own patient with ocular hypertension. Their pressures were in the 50s and the 60s. And he took their vessel density while the pressures were high, and the vessel density after the pressures have been controlled. And what he found was that the vessel density actually increased. And he's of the thought that the pressure may actually cause collapse of the vessels and a relative non-partition at the time of the scan image or capture. So that could also be a place where OCTA will come in. So the other part of it is where the source of the artifact, we've talked about this before, is same for OCT. Actually, for OCTA, one of the drawbacks is that the patient has to be dilated and the patient has to be still, because the scan is a deeper scan and the signal strength, it's hard to get a good quality in a patient that is uncooperative. Other thing that could happen to OCT applies here as well. Misalignment, vignetting, software breakdown, artifacts from blink, segmentation errors, opacities, and all. So to conclude, because of our time, it's still same biodata, date, time and eye, test algorithm, scan quality, the depth, that's the segment. The nerve fiber layer map is to your left, where the vessel density is to your right, where you have to do a quantitative and a qualitative assessment of the quadrants compared to a normative database. And you, the clinician, you have the history of the patient and other pull factors. You make your impression, take a clinical decision, and then that will be it. Okay, there are some references attached to it, and thank you for your attention. Let me check if there are other questions on the forum and other contribution. Okay, someone said, please throw more light on the value of the peripapillary vessel density. Okay, so, okay, now, the density is like checking, density is in the name, is just checking the quantity of the capillaries around the optic nerve head. The theory is this, that the retinal nerve fiber layer thickness, the retinal nerve fiber layer derives vascular supply from the radial peripapillary capillaries. They are capillaries. They are within the nerve fiber layer, and they supply the nerve fiber. So we say peripapillary because they are around the disc, and they follow the same pattern as the nerve fibers themselves, aching upward and downward, and then to the right and to the left, or nasal and temporal. So being that they supply the nerve fibers, checking them is as good as checking the vascular supply of the retinal nerve fibers. And that's where their importance is. The density, we said, is a measure put in the machine to quantify the perfused area compared to the whole area imaged. Meaning if it images an area, let's say 1 disc diameter and half of the disc diameter is unperfused, it will give you a vessel density that aligns with that. So that's where the importance is. The vessels within the disc are also of importance in glaucoma too. There are studies on it, and I think we could check and read them up, but the peripapillary seems to be the more studied type. So, and that's why I chose that in this presentation, and I've also done a little study on that. Yes, vascular conditions like diabetes and hypertension have an effect. They are vascular, okay? Any disease that could cause a generalized vascular condition could affect the vessel density, but is on patient basis. The study I did on the analysis and everything put together, the disease conditions had no association with the vessel densities. But yes, that could happen. And also watch out for hyperlipidemia. If your patient has hyperlipidemia, you may want to scan, control, and check again, and then you'll be able to interpret your results accurately. So never say never. Any factor you see in the patient that could affect your result, please go ahead and take care of that too. All right. Okay. Any more questions, please,
Thank you very
or
much,
contributions?
Dr. Umeh, for this scholarly and detailed presentation. We've all benefited from it. And we want to also thank Professor Adiola Onokoya, Professor of Ophthalmology and a glaucoma specialist. We really appreciate your erudite contribution to this presentation. Thank you very much, ma'am. I think most of the questions in the chat box has been addressed. I don't think there are more questions.
Thank you very much.
Yes, ma'am. So
Right.
I think we have come to the end of this academic session. We look forward to completing this presentation on OCT and geography. We still have to discuss the retina aspect of it, and we look forward to yes. So maybe the next session you complete the retina aspects of this presentation. So thank you very much, all the participants, for your questions and your contributions to this presentation. Let us have a wonderful week.